Welcome to your basic EKG interpretation presentation. In an adult with a healthy heart, the heart rate is usually about 72 beats per minute. The excitatory and electrical conduction system of the heart is responsible for the contraction and relaxation of the heart muscle. The sinoatrial node, or SA node, is the pacemaker where the electrical impulse is generated. This node is located along the posterior wall of the right atrium, right beneath the opening of the superior vena cava. It is a crescent-shaped area and is about 3 millimeters wide and 1 centimeter long. On this slide, we see an EKG strip. This paper is a grid where you can see both large squares and small squares. So let me outline here with my highlighter the large squares that I'm referring to. Okay, so each of these very visible squares is referred to as a large square. But if you look very closely, I know this slide is not the clearest, you will also see that there are lots of little squares within each of these big squares. Okay, and there would be 25 little squares within each big square. Now at the top of the paper, I want you to notice that there are, every 3 seconds, there's going to be a black line here at the top. That allows us to look for the and guesstimate the amount of time that those heartbeats have occurred in. For example, if we start here and go to the next black line, then we know that's 3 seconds of time. And if we go to the next line, that's another 3 seconds. And why I'm pointing that out is because as we learn to interpret these EKG tracings, we have to have a minimum of a 6-second strip. So it's always good to look at the top and make sure that we are using a 6-second strip and we're basing our interpretation upon that amount of time. Anything less than that would not be adequate for making an interpretation. Okay, let's review the normal components of an EKG waveform. First, I'm just going to point out at top we have the little lines that indicate time on the horizontal axis. So we have between these two lines 3 seconds. Indeed, this is not a 6-second strip, so we definitely would not want to interpret this strip. However, it is sufficient to show us some normal components. First, let's look at the P wave. All right. The P wave, you could even write the letter P above each of them as we're just learning. This is the P wave. So I have 1, 2, 3, 4, 5 P waves. And the P wave represents atrial depolarization or contraction of the atrium. The normal duration is not longer than 0.11 seconds, which is less than 3 small squares. Okay, the top of the P wave should be nice and rounded. Okay, there should be no notching or peaks in the P wave. Following the P wave is what we call the QRS complex. Okay. So you could also write letters. Q is always the first downward deflection. It's a very small q here. Q, R, S. and that's the QRS complex. It represents ventricular depolarization or contraction of the ventricles. So here we see that the QRS complex follows the P wave, and it does that in each of these heartbeats. We have a P followed by a QRS complex. P, QRS complex, P, QRS complex. So you see that the atria are contracting before the ventricles. Atria contracts before the ventricles. Normally, the QRS complex is not longer than 0.10 seconds in duration. The R waves are deflected positively. So here's the R. This would be considered the R wave when they refer to that. They're deflected positively, which means they're in the upward fashion on the tracing, not pointing downward. Okay. And the Q and the S are slightly negative, meaning they're pointing downward. As you can see, sometimes you can't even see the Q wave, but the Q and the S are pointing down, but the R wave is positively deflected. All right, so let's go on to the next component of our EKG waveform, and that would be our T wave. Okay, so we have P, QRS, T. The T wave, you can put a T over that, indicates ventricular repolarization or relaxation. It should be nice and rounded as well, just like the P wave. However, it is not symmetrical. It is asymmetrical. So whereas the P wave is the same on both sides, the T wave is not. If you drew a line right through the T wave, through the middle, you would see that they are not exact mirror images of each other. One side is a little different than the other, and that is normal for a T wave. Okay, so T waves are rounded, but they are also asymmetrical. So we have the P, QRS, T, P, QRS, T, P, QRS, T, etc. Okay. Now, another component that we want to look at here is the ST segment. Okay, so let's look at the ST segment. It's right here. Remember, here's your S, and your T begins right here. So we have this ST segment. Okay, and it indicates early ventricular repolarization. It's normally not depressed more than 0.5 millimeters. Okay, I'm not asking you to look at the vertical axis, but I want you just to understand that if you get into advanced EKG interpretation, you will look at those things as well. But in other words, there's a little bit of leeway. It doesn't have to be exactly straight. It can have a little bit of a depression, and that is not significant. But you don't want the elevation or depression to be more than 1 millimeter. Okay, so there's a little bit of wiggle room there, a little bit of depression or elevation, but not much. Okay, and then we have the final component that we'll talk about is the PR interval. And the PR interval is the amount of time from the beginning of the P wave, and we can probably see it better down here, the beginning of the P wave to the very first downward deflection, which is going to be representing your Q wave. So from this length of time, this duration from here to here, straight across, is referred to as your PR interval, and it indicates the atrioventricular conduction time. Okay, normal duration time for the PR interval is 0.12 to 0.20 seconds. In other words, we do not want it to be longer than 0.2 seconds. Okay, When it's greater than 0.2 seconds, we say that it is prolonged. Now, one other thing that this slide shows us are the squares that make up the EKG grid on the paper. Okay, so we've taken out just a single large square and we've zoomed in and made it larger so we could look at the little squares within. From one point, the large square, to the other end is 0.2 seconds. Okay, so if this is a given by the grid on the paper, and we divide 1, 2, 3, 4, 5 into 0.2 seconds, then we know that each little square represents 0.04 seconds. Okay, so those numbers or times we will need to memorize as well going forward so that we can make our proper interpretations. We want to memorize certain values, and certainly this is one. The length of or time for one large box is 0.2 seconds. The length of time for a small box is 0.04 seconds. Okay. This is a representation of how the EKG measures activity. At the top, you'll see a single heartbeat, P, Q, R, S, T. Okay, so if you want to see where what electrical activity is occurring in each of these components of our EKG waveform, the P wave is going to represent the electrical impulses across the atria. Okay, across the atria. She drew a line down from the end of the atria contracting, and this is what this area represents. And so the P wave represents the electrical impulse across the atria to the AV node. The QRS represents the electrical impulse, okay, as it travels across the ventricles. And finally, the T wave over here represents the electrical repolarization of the ventricles. This is a very nice picture of a single heartbeat, and we can refer back to it as we begin measuring these waveforms and time intervals, such as the PR interval and the QT interval. I just want to mention one thing while we're looking at this, and that's that it makes a big, well, I would say a big deal about this U wave here, okay? For our purposes, we are not even going to address the U wave in a basic EKG course. Most of the time, this is not even visible at all. It's kind of hidden under the T wave. So just, I would probably warn you never to pick the U wave as an answer because it's simply not going to factor into anything that we discuss. So kind of a, just put that aside there. So we'll stick with the P. First downward deflection is your Q, R, S, and then your ST segment, but your T here comes back down. So this whole line that we're talking about here, when we talk about positive and negative deflections, is referred to as the isoelectric line. Okay. And we are going to learn to measure durations or time intervals. And some of the time intervals that we're going to measure are on this slide. So we're going to learn to measure the PR interval, the QRS duration, and also the QT interval. So these have normal ranges, and that's why we're going to measure them. Just like lab results out of a test tube have normal ranges, so too do the electrical conduction times within the heart. So remember, if the conduction time is taking a long time, then we're dealing with the horizontal axis, so this would be all spread out. In fact, if it's taking longer for that electrical impulse to travel through the ventricles, for example, a patient that has heart failure, then we would expect that this QRS complex to be much wider. Okay, so hopefully you can envision that as we go forward. Anytime the term sinus rhythm is used to describe a cardiac rhythm, it indicates that this rhythm is initiated or started in the sinoatrial SA node, located in the myocardium of the upper right atrium, and that it follows a normal conduction route through the heart. For a sinus rhythm to be present, the following 5 EKG conditions must occur. A normal P wave must precede each QRS complex. Normal P waves are positive. Abnormal P waves are negative or inverted. The other EKG condition must occur is that only one P wave can precede each QRS complex. Also, all the P waves are the same shape. And all the PR intervals must be normal and the same length. Normal PR intervals are 0.12 seconds, which is 3 small boxes, to 0.20 seconds, which is 5 small boxes. Okay? In other words, we do not want a PR interval to be longer than 0.2 seconds or greater than 5 small boxes. Also, for a sinus rhythm to be present, we also need to meet another condition, and that is that the heart rate must be between 60 and 100 beats per minute. And finally, all the QRS complexes will be the same shape. In this slide, it's very nice because we see all the P waves are in red. The QRS complex or interval represents the time it takes for depolarization of the ventricles. Normal depolarization requires normal function of the right and left bundle branches. The QRS duration may vary with the size of the heart and is longer in the base apex lead. A block in either the right or left bundle's branches delays depolarization of the ventricle, resulting in a prolonged QRS duration. The T wave indicates ventricular repolarization. It is rounded and, as we said, asymmetrical. So if you drew a line down the middle, you would see that this side looks a little different than this side. Also, this slide is nice because it shows you in the neon green dashed line, this is that isoelectric line. And we use that to see if we have a negative or positive deflection. It's also very nice because it shows us the R to R interval. There are times when we will ask if a rhythm is regular or irregular. And I want to introduce those terms here because When the R to R interval between QRS complexes is the same along the strip, then that means that it is a regular rhythm. However, if the R to R interval measures differently between the R's of a particular strip, then that indicates that it is an irregular rhythm. Let's say a word about the ST segment. The ST segment represents early ventricular repolarization. As we said earlier, it's normally not depressed more than about 0.5 millimeters. And it's normally not elevated more than 1 millimeter. Remember, we over here on the vertical axis have voltage, so that's what we're talking about in terms of these measurements here. But we're not going to ask you if it's, if it's depressed or elevated. It's going to be very obvious if it is depressed or elevated for you all. Just know that it's okay for it to vary a little bit above or below the isoelectric line. Also, I will use this slide because it's very nice in showing us where we would want to begin our measurements and where we would want to end our measurements. For example, we see here the QT interval. When asked to measure the QT interval, we are going to place one point of our caliper here at the Q wave. So at the very first downward deflection is where you would place one point of your caliper. The other point would be placed right here at the very end of your T wave. This straight line, this measurement of time, is going to be the duration of the QT interval. Let's look at another measurement, for example, the PR interval. We measure the PR interval by placing one point of our caliper at the beginning of the P and the second point right there at the Q. I know it's a little bit of a misnomer. You would probably be happier if it was called the PQ interval, but it's not. So understand that we begin our measurement here and we end it here when we are measuring the PR interval. This distance, or this time, because it's on the horizontal axis, is this length of time. I know I was going to say something else, but it just slipped my mind, so we'll continue on. Okay, so here we have a close-up look of that single heartbeat and also the grid. We know we have a large box. Within that we have small boxes. And this will also allow us to know where to begin our measurements and end our measurements when we're talking about the duration of these various intervals. So this would be a very nice slide to come back to because it will be very helpful as we begin our measurements. The PR interval is the time in seconds from the beginning of the P wave to the beginning of the QRS complex, or as I like to say, until the first downward deflection, which represents the Q. It corresponds to the time lag from the onset of atrial depolarization to the onset of ventricular depolarization. This time lag allows atrial systole to occur, filling the ventricles before ventricular systole. Most of that delay occurs in the AV node. A prolonged PR interval corresponds to impaired atrioventricular conduction. Remember, a normal PR interval is 0.12 to 0.2 seconds. We're really not too concerned about the lower limit of normal, but we are very concerned about the upper limit of normal, because when it's prolonged or greater than 0.2, then that indicates there's an impairment in AV conduction. Now let's speak about the QT interval. The QT interval is measured from the Q, the first downward deflection, to the end of the T. It represents ventricular depolarization and repolarization. Okay. Now that we have some foundational knowledge regarding EKG components, let us begin the steps needed to interpret our tracings. We always begin with calculating the heart rate. Okay? When I talk about calculating the heart rate, I mean getting a rough estimate of the heart rate by glancing at the EKG strip. Okay. We have two methods. The first method I'm going to tell you about is called the large square method, and that's when we divide the number of large squares between the QRS complexes into the heart rate. For example, if we see that there are 4 large squares between QRS complexes, then we divide the number 4 into the number 300 and we get 75. So that is a rough estimate of that patient's heart rate. Okay? It's not exact, but it really doesn't matter for our purposes if it's 74 or 77. What difference does it make? They're both normal. So we can simply glance at a EKG strip and visually see how many large squares are there from the R to the R. If there are 4 and we divide that into 300, we get 75. And so that is one method of doing it. The second method that can be used is to simply count the number of R waves in a 6-second strip and then multiply that number by 10. For example, if there are 7 R waves in a 6-second strip, then multiply 7 by 10 and you get 70. So the patient's heart rate is 70. At least we know that it's normal. It's not too slow and it's not too fast. Okay, so that's the first step we want to do when we are beginning to interpret rhythms. Let's take a look now at sinus bradycardia. First, we're going to look at the tracing and double check that our strip has a 6 seconds, and indeed it does. So we can go ahead and begin to interpret this finding. The rhythm sinus bradycardia is often seen as a normal variation in athletes during sleep or in response to a vagal maneuver. Sinus bradycardia, first we look at the rate. It's determined to be sinus bradycardia if the rate is between 40 and 59 beats per minute. So let's use the method that we've just studied, and I'm going to count in a 6-second strip the number of QRS complexes. 1, 2, 3, 4. 4 times 10 is 40. So this heart rate is approximately 40, a little 40 something. Okay, so we have a rate that's between 40 and 59. So it is slow, and that's where we get the bradycardia from. Okay. There are other things that we have to consider here. we cannot say that a rate is sinus until we confirm that there is a P wave in front of every QRS. And here it is. So that means that the SA node, the pacemaker, through these impulses that resulted in an atrial and ventricular contraction. Okay, so this is a sinus rhythm because a P wave is in front of every QRS complex. It is Brady because the rate is slow. Okay, it falls within this range here, 40 to 59. Another thing that we have to look at before we say this is a sinus bradycardia is to measure the QRS. Normally, the QRS complex is a narrow complex. Okay, it's not wide, it's very narrow. It's hard to even count the number of small boxes in that QRS, maybe 1 or 2 here. Okay, so if there's 2 small boxes, and I'm not saying there is, there may only be 1 and 1.5, then you have between, you have about 0.06 to 0.08, and that falls within the normal range for the QRS. So when you see a very narrow complex, you know that it's within the normal range, and then we have a very short duration for the ventricles to contract. That's going to be an efficient heart. Okay, the problem is when that QRS complex is wide. In other words, the QRS is greater than 0.12 seconds, which is 3 small boxes. And clearly on this strip, the QRS is not wider than 3 small boxes. Okay, so there is no prolonged QRS here or very slow conduction through the ventricles. The PR, in this case, we also have to look at that before we're going to say or interpret that it is a sinus bradycardia. We have to look now at the PR interval. The PR interval, remember, starts here and ends here. So it's this length of time here. And this is a nice slide because we can see from the beginning of the P to the first downward deflection, it all is happening within one large box. So clearly we have a PR interval that is within the normal range because if it's prolonged, it's greater than 0.2 seconds. And here, one large box is 0.2 seconds. So we know that the PR interval is normal, and therefore that's also an indication that this is a sinus bradycardia. If the PR interval is prolonged, that brings us into a whole nother category of heart blocks that we haven't even spoken about yet. So here we have a normal length of our PR interval, less than 0.2 or less than 1 big box. Okay, so let's mention how we treat that sinus bradycardia. First, we have to remember that perhaps bradycardia is normal for this person. Certainly it is normal for athletes who have a well-conditioned cardiovascular system. Their heart doesn't need to beat more than 58 times a minute, for example, and they are able to perfuse their body very well. And then we have people who are asleep who fall down into a sinus bradycardia, and there is a simple intervention. If you're concerned about it, then just wake them up and see if their heart rate doesn't bounce back. So there are normal situations in which patients present in a sinus bradycardia, and certainly we have to mention our patients who are taking beta blockers. Okay, the whole reason they're given a beta blocker is to slow down their heart rate. They don't want their heart rate to go up higher or faster because then it requires the heart has more, there's more demands on that heart. So the physician has purposefully prescribed a beta blocker to slow the patient's heart rate down. That too is nothing to be concerned about. However, we are going to be concerned about our patients who are in a sinus bradycardia and they are symptomatic, okay? Or they are hemodynamically compromised. Then we have to treat them. The medication that we use to treat sinus bradycardia is atropine. Okay? Atropine will increase the patient's heart rate. Another option would be the medication Isuprel. And finally, we have another option where we could do artificial pacing for the patient to get that heart beating faster at a heart rate that can help to improve cardiac output and perfuse the patient's body. So do not overlook this as an alternate. When a person has sinus bradycardia and they are symptomatic and hemodynamically compromised, yes, perhaps they need a pacemaker of some sort. We have all kinds of options we'll talk about in our pacemaker module. But we can have temporary, we can have external, internal pacemakers. So that is an option for this patient. Moving on to our next rhythm, sinus tachycardia. Again, a quick glance at the top of the strip shows us that we probably have a 6-second strip, so we can interpret it. The next step is going to be to count the R's, QRS complexes 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. About 12. So we have 12 times 10, or 120, would be our rough estimate for the patient's heart rate. The rate for tachycardia is over 100. So 101 to 160 beats per minute would indicate that the heart rate is above normal and it's tachycardia. Now we have to take another quick look and see if we have a P wave in front of each QRS complex here. And indeed, we do. There's a P wave, P, QRS, T. So there's a P wave in front of every QRS. That tells me that it is a sinus rhythm. Now also, while we're looking up here, I want you to look at the distance between the R to R's. Are those the same? Is the R to R distance the same? And you should say, yes, it is. And one way that we could find out is by using our calipers, and we'll do this in class. You'll put one point of your caliper here and the other point on the next R wave, and then you'll rotate the top of your calipers, and when you rotate it, the tip should land on the next R wave. Rotate it again, it lands, and it does this where it does march out. And what that's telling us is that we have a regular rhythm. Okay, so sinus tachycardia is a regular rhythm, and this is indeed sinus tachycardia. There's only two other things that we want to look at, and one of them would be the QRS complex. Does the QRS complex shown, are they described as narrow or wide? And you would be correct in saying that they're very narrow. In fact, we can hardly even count the number of small boxes between them, maybe one. Okay, so it's very narrow. The QRS is not prolonged, indicating a delayed or slow passage of the conduction through the ventricles. So that's normal. And then finally, we look at that PR interval. And we can see from the beginning of the P to the first downward deflection, your PR interval, is it less than 0.2, which is one large box? Indeed it is. So it's normal, or more importantly, not prolonged. Okay, so that conduction is normal. So this is an exact representation of somebody who has a sinus tachycardia. One other mention, if there's a tiny little bit of variation or slight irregularity, that's not an issue. None of these hearts are perfect as we may have them drawn out, in a diagram in a textbook. So we do give a little bit of wiggle room for these rhythm strips, okay? Don't be too exact. It's just not that important.